Hi, I'm Simon Jones and I chair the Special Advisory Group for the Children's Pediatric Podiatry. This year's conference was due to take place on Friday the 26th of June and obviously, unfortunately, due to current circumstances, we're unable to meet together and chat about all things paediatrics as we normally do on the last Friday of June, for which obviously I'm very sorry and we will miss it greatly. By this point we should have been having coffee and pastries and smoothie shots, moving on to a nice lunch. But unfortunately, I'm now sat in the garden alone without you around me. Our endeavours have been to try and put this conference on, so our decision we had to make was to come to a virtual one for today, the 26th of June, which I hope you thoroughly enjoy. We've put quite a lot of effort into making it interesting and applicable and practical, as we always do. And of course, we will hopefully be going back to our normal conference on a Friday in March. The date I will let you know as soon as I have it and confirmed it with the venue, which obviously is tricky at this time. I hope you fully enjoy the morning. During the morning, the speakers will be available online. So if you wish to ask them any questions, please just type into the chat, into the YouTube channel, and they will answer. If they can't answer during the morning, they will get back to you at some point soon, hopefully during that day. This is obviously dependent on how many questions and if we need to find any more information. I hope you thoroughly enjoy it, and any questions or problems, please don't hesitate to contact me. And I can't wait to see you all in March when we can see face to face and give each other hugs. Best of luck, take care, and enjoy the morning. Thank you very much. Bye. Hi, I'll now go for the housekeeping rules for this morning's online conference. Coffee and tea will be provided by yourself and any soft drinks. The toilets are probably upstairs, although some of you may have them to the left or the right. If there is a fire, we are not anticipating any fire or any trial this morning, but if there is, then please exit the building from the nearest exit. That will be the front door or the back door, maybe the conservatory door. If you wish to go to the toilet, please just do so, as this will not interrupt anybody else. And please take notes. This morning's lectures will all be available online for you to view from now onwards, and you can view them in sections, or you can view them all at one time with your own refreshments by your side. Unfortunately, we are not providing refreshments for this online conference, for which I apologise profusely. Many thanks and good luck, and enjoy what you're about to see with our wonderful speakers who've been assembled throughout the world. And I hope you have a good morning of learning. Thanks very much. Bye.
Morning, everyone. Hope you're enjoying lockdown. Really good of you to take some time out to attend our conference. I'm Mark, and I'm going to talk to you about a case study about lateral foot pain. A really small area. Okay, so this is Alice. Now, Alice is an 11-year-old female. She was complaining of about 2-month history of pain to the right lateral foot. Really sporty girl, played netball, football, but her main passion was athletics. She was a hurdler, so she hurdled for her school. Got to the point where she was unable to train properly. Pain was just stopping her, and she was getting a little bit worried about it. It was also painful after about 20 minutes of walking. The referral come into us, and unfortunately, due to our wait lists, she went to see a private AHP who diagnosed flat feet and tendonitis. Gave her some over-the-counter insoles, said to return in 3 or 4 weeks, see how she was getting on. Luckily, the referral, we managed to jump the referral. We had some cancellations. We got her in. She saw one of our NHS pods who did a really good workup, had a good look at her. Wasn't 100% sure what the diagnosis was. Wasn't able to arrange any imaging, so she wanted to get a second or third opinion. So she referred into our joint paediatric pod physio clinic. So when we saw Alice, good general health, no familial history of anything, no significant birth or development history, really fit and healthy girl. When we were talking to her, there was no history of trauma for this injury. It kind of niggled a little bit, and then it started to get a little bit worse gradually. But no trauma, didn't have any injuries or anything like that. So that was quite an important question. And we had there was a little bit of localised swelling, marginal redness around the styloid area. There was no break in the skin. There's no corns, no callus, no fissures, no sign of any dermatological reason why she'd be getting this, or any pressure reasons why she was getting this. It was tender to palpate. It wasn't ridiculously bad, but it was painful enough compared to the left. When we were testing her, going through testing, she had minimal discomfort on inversion resistance, and tested compared to the left. It was tender when we got her walking on tiptoes. There was no pain on heel walking. All her other neuromuscular testing was fine. Reflexes were fine. All her other muscle strength was fine. She was a really strong, healthy girl. One other thing that Mum said and come out in her history was that she'd had a recent growth spurt about 2 months ago as well. So again, that's quite an important part of the history. So we're working on our differentials for this young lady. So as the previous AHP had told her, possibly tendinopathy. Personally, in the cohort of kids that I see, we do get a lot of foot pain. I would say a minimal amount would be down to tendinopathies. That's just in my cohort. Other practitioners may see a little bit more, but when you're thinking about tendinopathies, tends to be a degenerative part to a tendinopathy, and you're not going to get degeneration of a tendon in a kid. They may get a tendinopathy from an injury, so that's something that you need to look into. Fracture. So obviously from the questioning, we said there was no trauma, no sudden pain, no injury. She didn't twist her ankle or anything like that. So we thought we could probably rule it out. There could be a chance of a stress fracture, but the way the pain history was, it wasn't that indicative of a fracture. So we talked about pressure, corns and calluses and things. At the time, she had good fitting shoes. They were Vans that she came in, so they were very flat, very soft. She brought her spikes and her trainers in, so her spikes were a pretty snug fit. A bit difficult to test what was going on with those, but she was saying that she was getting the pain when she was training. She trained in her trainers, obviously, as well. So, couple of different footwear types were causing the pain, and she was getting pain when she was walking after about 20 minutes as well. So unlikely to be any of the footwear. So we're thinking about a growth plate around that area. So attraction apophysitis, ideally Isselins. So thinking obviously our work, building up our work in diagnoses, and in some instances with these you do need an x-ray to confirm it along with your history. But her history was suggestive potentially of this as well, along with the insidious nature of the pain and the growth spurt that her mum was talking about. Obviously, in the back of your mind, you always need to be thinking about things like neoplasms. They are very rare, but obviously we do need to think about them. It should be in your differential diagnosis. Again, really good history. And if you're worried, if you're unsure, and if things don't start turning around or you're hitting a brick wall, refer on or get some imaging if you're worried. So just a couple of complications. We talking to mum about our differentials, and we said, you know, we're going to go along with a treatment plan which may involve some imagery. Mum didn't want her to have an x-ray. We talked through risks, radiation, etc. So she really didn't want to go down that line, which is fair. It's not something that we routinely do with kids, send them for x-rays, but you know, it's there as an option. We do have ultrasound in clinic. I myself am actually training it at the moment. I wasn't overly confident about scanning this girl. I thought if we get her on a treatment plan, do a referral for an ultrasound for an MSK sonographer, I think it'd be a little bit better than me having a look. And the other option would have been an MRI, which we have access to, but because she's 11, she's under the age for the contracts in CCG, so that was ruled out. So using an ultrasound would have been a really good option, safe, etc. So talking about our treatment plan, our treatment algorithm. So we started off, we advised resting from sport, especially propulsive and impact sports, for about 2 weeks. If she was getting any aggravation, we advised cold packs. You know, we know the evidence for ice isn't great for healing, but with kids, makes them feel better, gives them a little bit of security, numbs the area if it's a little bit uncomfortable. So in a lot of cases, though the evidence is weak for it, it's quite a good thing to do psychologically for the kid. Gave us some footwear advice. We need to maintain good footwear, but try and get shoes with a little bit of a heel, just to take a bit of pressure off of that lateral border, rather than wearing flat Vans. One thing I didn't mention is earlier when she was given an over-the-counter heel arch filler inside by another AHP, which is fair treatment plan to go with, but she did say after about 2 or 3 weeks of wearing it that it was exacerbating the symptoms a little bit, and she felt that it was putting a lot of pressure in her shoes, which could have been exacerbating her symptoms as well. So we took that out and we used just a simple insole with some lateral posting to Bryonis brevis. We decided on a perineal stretching and a tentative gradual resistance program with a yellow TheraBand after the 2 weeks rest. Really, really gradual stuff, no high loading as you would in a tendinopathy. We just wanted to maintain a little bit of strength while she was resting. So we plan to review her in 4 to 6 weeks and see how she was getting on. So as a follow-up, 6 weeks on, pain had reduced dramatically, still niggled a little bit occasionally. She wasn't back to doing full sports, but she was taking part in PE. So we decided to carry on with the current regime, added foot and lower limb strength work with a wobble cushion to try and increase her proprioception. She'd been resting up. She hadn't done a lot of sprinting. She hadn't done a lot of hopping or jumping. So we wanted to increase her proprioception a little bit and strengthen her up a touch as well. We added a gradual increase in activity. So starting off with walking as long as her pain scales were low, then a walk to run, almost like a couch to 5K type program. Added in, as she got a little bit better, plyometrics, so skipping. And when she felt that she could do all of these things without any pain at all, and she was really confident, we advised her to try and do a bit of sprinting and maybe get back to trying a little bit of hurdling. Came back after 12 weeks. She was pretty much back to normal activity. Started hurdling. She was training. She wasn't taking part in any competitions or races or anything like that. But she was happy and she wasn't in any pain. So we discharged her. So the top of our working diagnosis was Isserlin's. So Isserlin's disease, I'll put disease in inverted commas. It's not really a disease, and we shouldn't be calling it a disease, but it was first described as a disease by a German physician called Isserlin in 1912. So it's painful apophysis of the fifth metatarsal. So right at the end, the base of the styloid process. The apophysis is in the peroneus brevis insertion site. So these apophyses they're basically growth cartilage. It's a weak link between the muscle and tendon junction. So if you think about when a child's growing, this is the area that allows the bone to grow. They go through a heavy growth spurt. A lot of the kids we see who go through these heavy growth spurts and really fast growth spurts tend to get these apophysitis. So we don't know 100% why it happens, but one of the thoughts is that maybe due to rapid growth, there are periods that are associated with structural changes within the growth plate. So if you think about where the tendon inserts and it originates from, if they're going into soft cartilage rather than bone, as in adult skeletal mature bone, it's not going to be as strong. So it's a weak point, and that tends to be where you're going to start getting pains. So it appears radiographically at about age 10 in females, age 12 in male population, usually fuses by 11 in female and by 14 in males. As we said previously, it's believed to be caused by repetitive microtrauma from traction peroneus brevis. Therefore, we term it a traction apophysitis rather than a disease. So just a little diagram here with a couple of differentials and what you'd be looking at if you were looking at an X-ray potentially. So you've got different types of fractures. You can see where the fractures are going across the base of the fifth metatarsal. Ospithalinium is basically an accessory bone in the peroneus brevis. And you can see that on X-ray. But if you ever look at the Isserlin's disease, it's a longitudinal fleck where you see difference between the edge of the bone and the main metatarsal. So that's going to be where the apophysis is. That's what it looks like on X-ray. So you're looking, this is an oblique view. So you're looking for a longitudinal fleck and that little gap there. You can't. There's no fracture lines coming through the metatarsal. You can't see an accessory bone. You can just about make out the tendon here, peroneus brevis as well. So just to summarise, when we're treating kids, be aware of growth plates and apophysis. There's quite a few in the feet, and you need to be aware of them. Obviously, you're going to have some differential diagnosis to work from, but this is why they're different to adults. Remember, they're growing, so really important to take a growth history. Whether it's a real slow growth history or if they have spikes, if you see real growth spurts, likely is you're going to start getting these pains in the kids who grow really quickly in spurts and are quite sporty. On top of everything else, with everything else we do, when you're doing an assessment, history, most important thing in the world. So you're going to get 90% of your diagnosis with this, with a good history. Obviously, we talked about earlier, if there'd been an inversion sprain, an injury, a traumatic incident, we'd be looking at having a fracture at the top of our list. So you can work out your treatment plans if you take a good history. just a few references for you there. And that's me done. Thank you for listening. Hang around if you've got any questions.
Good morning. My name's James Welch, and I'm a podiatrist in Surrey, and I'm going to talk to you today about hypermobility and the paediatric patient. We're going to have a look at hypermobility and how it might affect one of the children that come into our clinics, and what we might be able to do for them from an assessment and treatment perspective. And also hopefully give us a broader overview of hypermobility and the conditions that it can be a symptom of. So we're in Surrey, so people assume that everyone rides horses and has a butler, and this little girl, Xanthi, 7 years old, comes into clinic, and she has been complaining of pain in her ankles and her knees and her hips from first thing in the morning. And this pain continues throughout the day with no abating. She has dislocated her left knee twice, and she can be rather reserved due to this constant pain. But her parents are pretty cool. They say, look, she's not a child to complain. And she's been told by a previous clinician of some sort that she's hypermobile, but no more information apart from that. So being the clinicians that we are, first things first, initial assessment, and we go through a real thorough history. This is the most important start. So talking to this patient and her parents, they've undergone a full-term pregnancy, no gestational difficulties, born via vaginal delivery, and she weighed 7 pounds. So she's a very average weight child for now. An APGAR score was 8 for any students watching. An APGAR score is a brief score to summarize the health of a newborn child and their newborn baby. And there's a range from 0 to 10, 10 being what you want. And the letters stand for appearance, which is your skin color, so ranging from blue to pink. P for pulse, so over 100 beats per minute score, and you can, if you do that, you score 2. Grimace, which is response to stimulation. Activity, which is muscle tone. And respiration, which is vigorous cry. And you want to score up towards 10. This young girl, the mother reports that she wasn't crawling at 12 months old, and was not even cruising at the age of 18 months. And she actually only independently became mobile by the age of 2.5. And she also reported that she had difficulty using cutlery, holding a pen, fastening buttons. And from the past medical history, there was a maternal history of Ehlers-Danlos syndrome, hypermobile type 5. Now, with regards to the assessment here, things like by the age of 7, I would expect children to be able to start to use cutlery. They should be able to hold a pen. They should be able to fasten buttons. And these scores start to make us think about what children should and shouldn't be able to do. Now they are a guide, they are a range, but it just makes you think a bit more about when they're outside of what you would want for normal. So for me, the average age for children walking independently can be anything between 9 and 20 months. Now, there needs to be reasons as to why this is delayed, but obviously with this child, we have pre-existing things here. So 12 months, 18 months, they're not following a normal pattern. Anyway, so, and some of the phrases, some of the things that I get told or either get put on a referral or anecdotally said by parents or relatives, and it will be things along these lines. He's struggling to walk, told he's hypermobile, but we don't know if it's a problem, so they don't know that they're told it is or it isn't. There's a lot of talk about control, as in something's not working, so therefore it needs controlling. So I've had patients, yes, she needs orthotics to control her hypermobility. Falling is another, in respect to their classmates, their peers, regularly told, oh, they've been told it's growing pains or things popping out. And the final one here was one where, yeah, they were told that they had flat feet and they needed correcting. So immediately they've thought that this is a problem, this is an issue which needs fixing, which is a whole other debate in itself. So we need to start at the beginning. Obviously the presentation is on hypermobility, so we need to actually know what hypermobility is. And so if you want to look up any work after the presentation, look up the work of Professor Rodney Graham. He is the absolute guru with regard, and Dr. Alan Hakim as well. But Rodney Graham, he makes the note that hypermobility is an excessive range of motion in any given joint over and above what we would deem a normal range of motion. And this is backed up by several other authors. And we know that joint hypermobility is common in the general population. It can be in some joints, it could be widespread. And we know from the evidence base it's most common in childhood and adolescence, more in females and more in Asian and Afro-Caribbean backgrounds or races. We also know that it lessens with age, but in many people it just has no medical consequence and doesn't give rise to any symptoms. And some people would even deem it advantageous. But it can also be associated with joint and ligament injuries, pain, fatigue, and other symptoms. And a little red flag would be that actually occasionally it's a sign of a more serious underlying condition, which could often be passed down through the generations. And as we know, with our patient here, if you look back at the medical history, she has a maternal history of Ehlers-Danlos syndrome, hypermobile type 5. So it may be a red herring, but it's something when you're doing your history with the patient, you've got to pay attention to things like that, because all these little clues can help you out no end. But anyway, these conditions are known as hereditary disorders of connective tissue, and there are a whole umbrella of them. But the difficulty we can have with things like this is the patient is given this diagnosis of hypermobility, and for a lot of patients it's nothing. It's completely, as I've said, inconsequential. But they get this label, and it can actually be detrimental because they then start to pin any ailment, any problem onto the hypermobility and say that's the problem which is causing everything. And actually spotting the hypermobility is one thing, but being in a position to establish its clinical importance is quite another. And back to Professor Graham and Dr. Alan Hakim, they stated that the act of recognition becomes the goal in itself rather than the medium through which effective therapy can be provided. I think that's a really important note to bear in mind. So, as I just alluded to, the hereditary disorders of connective tissue, there's over 200 actually. I don't know all of them. I don't know a lot of them, but some of the most common ones are featured in this diagram here, especially things like Marfan syndrome, Ehlers-Danlos, osteogenesis imperfecta, to name 2 or 3. And actually, now I think of it, a very useful website is run by the Hypermobility Syndromes Association, and it is hypermobility.org. Look it up. That place is a wealth of knowledge. There is so much information on that website, and it's all backed up by Professor Graham and Dr. Hakim as well. And with these conditions, nearly all of them have some form of gene mutation, which are all shown in the various circles. And then hypermobility is a common feature of these conditions, apart from Marfan, less so in Marfan syndrome, but the others definitely. And what we need to look at really is whether this trait is a benign physiological variant, or is it a manifestation of one of these conditions. So we know about the maternal history of Ehlers-Danlos, so let's look in more detail actually at Ehlers-Danlos. So originally this was broken down in that they had 10 different types of EDS. Then it used to follow something called the Villefranche criteria, which made it to 6. And then they thought, no, we want to mess you around again, and we're going to change the criteria once more in 2017, which now means we have 13 different types of Ehlers-Danlos syndrome. But we're going to focus on the hypermobile side of it. And just as an aside, while I think of it, the actual emblem, this is where you have to think outside of the box. The emblem for the EDS Society is actually a zebra. And the thought process behind this was based on work done by medical students, where they would use the phrase about if you hear horses, expect, if you hear hooves, expect horses, but don't forget about the zebras. Basically meaning common things occur commonly, but don't forget about the rare conditions which are out there equally the same. And I've just pop this in. Some of this is no longer relevant because the criteria has changed, but this just for a very brief moment works as a very useful aid memoir with various different bits of clinical history for each section, and then how it would break down into the various hereditary disorders of connective tissue and the previous criteria that they used to use. And this is also, it's very necessary to exclude other signs of sort of connective tissue issues, and also looking at family history, so you have your clinical signs and indicators within that. So as I was saying about the criteria, so this is actually from the HMSA website, and this is the international consortium with the Ehlers-Danlos Society, so that they could find answers to these questions. So on the left-hand side, as you look at it, is HSD, so hypermobility spectrum disorder, at one end of which these patients will have not a lot wrong. On the right, you have hypermobile type Ehlers-Danlos syndrome. And this is defined by the new 2017 criteria, which I'll go through in a moment. And that's why you have the change in the terminology here. So with type 5, hypermobile EDS, you have an individual, they must fulfill each of the 3 domains. And in the second domain, they must fulfill at least 2 of the 3 descriptors, A, B, and C, to get the correct score. So domain 1, the presence of generalized hypermobility based on the Baton score or a 5-part questionnaire. So the Baton score, we will go on and talk about in a minute. And then domain 2, A, skin or fascia signs, marfanoid features, I'll mention those in a moment. Family history, we talked about that with regards to our patient, and at least one of the following 3 presentations. So you've got MSK pain, 2 or more limbs, for 3 months, widespread pain, greater than 3 months, or dislocations, things like that. And then domain 3, absence of any other underlying problems. So as I said, we'll look at, apologies for the busy nature of this slide. So the domain 2A, skin and fascia. So these are things like soft velvety skin, hyperextensibility, stretch marks, little papules on the heel that you see, little bubbles, atrophic scarring, hernias, pelvic issues. Marfanoid features, look at the face. You must look at the patient's face because there can be really high and narrow plate dental overcrowding. Obviously, valve prolapses we can't see. Arm span we know. Arachidactyly, so they're like long spider-like fingers. And with the test here, it's Steinberg sign. So Steinberg sign is when you have your hand like this and you put your thumb across and close your fingers over, and the thumb protrudes out the side. And the other one, Walker-Murdoch sign, is when you have your wrist like this and you try and clamp your thumb and your finger over like so, and they overlap. I mean, I can't get anywhere near, and I've got skinny wrists, so no. And then on the other side, you had your hypermobility spectrum disorder. So, and actually there's 4 subtypes of this as well, ranging from just your generalized to peripheral, localized, or even historical. And these each have their own criteria as well. And generally, if you look at the first one, this is used the Baton score and secondary MSK manifestations. And these are things like pain, soft tissue trauma, small tears in fibers and connective tissue, sprains, strains, altered proprioception is another, which sometimes is mistaken for being clumsy. And then even mention of flat feet in here as well. So other sort of MSK traits that can be related between soft tissue and mechanical forces during growth. And we see an autosomal dominant pattern of inheritance with this, causing systemic tissue laxity, collagen mutations. And we know from Rodney Graham's work, it is poorly diagnosed. Actually, greater than 50% of the patients that have the diagnosis is delayed for up to 10 years. And this can have a real progressive decline in these patients' quality of life. 45% of his referrals, this was 2006, that work, were accounted for routine general rheumatology referrals. And just this goes on to show how things can deteriorate, where you start with your pain and instability, and then you have this overlap with connective tissue problems, skin and habitus, uterine and rectal prolapse. So you start to have major issues, chronic pain, anxiety, so things like panic attacks, agoraphobia, and then dysautonomia, so things like palpitations, fatigue, chest discomfort, pre-syncope, and then GI dysmotility. So these are dysphagia, bowel problems, gastroparesis, constipation, rectal evacuatory dysfunction. Really, really difficult scenarios to be in, which end up coming on to progressive disability on a day-to-day basis. So there is this realization that HSD is a multi-systemic illness rather than a mild, seemingly trivial mechanical disorder of lax joints. So, and it's taken a long time for this sort of evidence base to come around to show that actually it needs to be taken very, very seriously. So back to our patient. So we've gone through all of the history, and we want to assess our patient. So hands-on, we've done the verbal side, but hands-on side. So the two sort of starters here would be the Baton scale and the lower limb assessment score. So your Baton scale, this little fella here, this was based in 1973, and actually back in 1997, when they used the Villafranche criteria, you used to use it with the Brighton criteria to diagnose hypermobile type EDS. And then the 5 sections, you score out of 9, you score little finger, suppressive dorsiflexion of your little finger of more than 90 degrees. The hand must be placed on a flat surface to do it properly. If you do it in the air, you get a false response. So it's 1 point for each. Passive apposition of the thumb to the flexor aspects of the forearms, 1 point for each. Hyperextension of the elbow more than 10 degrees, 1 point for each. Hyperextension of the knees more than 10 degrees, 1 point for each. And foreflexion of your trunk with knees straight, so your palms are rested easily on the floor. And this actually was based on the work, the technique work done by Carter Wilkinson back in 1964. But a downside is actually this scale was never intended for clinical use. It was actually designed for epidemiological studies. So why we're so reliant on it, well, concerns me. And actually the patient group it was based on was very small as well. And there are other issues here. Yes, it is a simple scale and it's very quick to use. You can get it done in less than 30 seconds, which is great. But for us as podiatrists, it only uses one lower limb marker. And when they adapted it, for some reason, they took out an excessive range of passive dorsiflexion of the ankle and eversion of the foot, which was already in it. And it only tracks a small number of joints. Therefore, some conditions may be missed. And why 5 out of 9? This is, again, one for the students out there. Have a think about it. Why 5 out of 9? Not 4, not 6, to classify you as hypermobile. So we look at the lower limb assessment score. And this was done by Jill Ferrari and her team back in 2005. And the aim was to see if the Baton scale was a reasonable measure of lower limb pathology. And it aimed to investigate whether a lower limb scoring system would fail to identify any children defined as hypermobile by the Baton scale alone. And this scale better distinguishes children with hypermobility in the lower limbs and hence is more directly applicable for us as podiatrists. So it included movements of the joints occurring in several planes of motion rather than just one direction. And it takes about 15 minutes to complete. So that's why people don't use it as much, because it is quite long-winded. It's out of 12, and 7 out of 12 is defined as hypermobile. And just whizzing through what it is. So you have your hip flexion and hip adduction, knee hyperextension, knee anterior draw test and knee rotation, ankle joint dorsiflexion, ankle anterior draw test, subtalar joint inversion, mid-tarsal joint inversion, mid-tarsal joint abduction and dorsiflexion and plantar flexion, MTPJ movement, and excessive subtalar joint pronation. I'm not going to go into looking at excess subtalar joint pronation. But the idea behind it was that they got you to walk on the spot, stop, invert your feet and relax. And does the arch completely flatten with a talar bulge medially, and looking at end subtalar joint range being reached. So what are our options? We've gone through our assessment, we've got our history, we've done all the tests that we wanted to do, and where do we go from here? Because we're now in the treatment phase for this young girl. So before we carry on with what we do, I'll stress at first, the words we use and how we talk about stuff is really important. We need to be really mindful of the terminology we use, because the problem with it is that if we start using certain types of nocivic terminology, words like damaged and broken and fixing and correcting, it can inadvertently do years and years of damage to the patient or their mindsets, because they think everything is horrendous. These patients will quite often come to you already a part of a physio program, or hydrotherapy is fantastic for these patients, just improving their strength, their proprioception, their stability, and these are an essential part for these patients. And orthoses. Now, orthoses for these patients can be beneficial. Some preferring potentially the UCBL type device, but not for all. Some patients can't tolerate it. They find it too uncomfortable, too painful. And even in some cases, some of my patients have said they prefer the feedback they get from their orthoses. And they've said whether it does this or not, they have said it makes them feel more stable and more secure. What we can find with regard to footwear for these patients, Pedro boots have been great. Again, this feeling of stability and security, but again, not for everyone, because Pedro boots are heavy. And one of the things we talked about before is that these patients, they fatigue quickly because they're having to work so much harder than sort of average Joe Blogs to deal with their day-to-day life. So you've now got to put them in something that's basically like a set of hobnail boots. So they're going to get more tired more quickly and therefore potentially have more problems. So even something like DMs I've found in the past may be appropriate. And also getting the patient and the parent on board with this, with education. So this ties all the way back into the first point. They need to be aware this problem isn't going to disappear. They need to learn how to manage their symptoms on a daily basis. Both the child and the parent must be on board with this. So they need to know it's going to be a long-term program, and the same with you by their side as well and helping them along. So in summary, make sure you take a thorough history. It can be complicated, okay? So the history, I cannot stress it enough. It is so important. Remember, there's more than just the Baton scale, okay? So use your noggin and think, right, okay, I've got that as my guide, but there's other stuff going on here as we looked at before. And is it a normal variant or is it something else, okay? Is it just that they're at the other end of the spectrum and they're just a bit more flexible than you and I? Or is it actually a red flag? Is it a significance that shows us that actually these patients need more help? Thank you. Any questions? Greatly appreciated. And you can catch me on either of these email addresses. I'm also on Twitter at AbleFeet, and that's my NHS one and my private one. So please give me a shout if you have any questions. Anyway, hope you enjoy the rest of today's lectures. Thank you very much.
I'm Nina, and I'm going to present Children and Family Centred Care. And thank you for joining us for this online conference. I do hope you're enjoying it. So by the end of this presentation, I hope I've given you an introduction to Children and Family Centred Care and given you some examples to take back to clinic, and also to develop the services you provide for children and families, and also to give you some confidence to practice the child and family centred kind of approach. It all starts, this child and family centred approach, in that we want to treat people as individuals, and we want to put people in the centre of their care and give them control and that confidence to self-manage. And this phrase here, people like to pigeonhole you, it's easier. And it's really trying to say that, well, in this case anyway, is that we want to move away from that kind of, what I would call that wholesale care, in that we assume what people need is best, and that you are the centre of those decisions. And we would like to move away from us being in control, or as much control, in consultations, and handing it over a little bit more to children and families in the consultations. So the shift to person-centred care in a diagram form, paternalism in terms of the practitioner knowing best, they're being at the top of the tree, and they are there advising the patient what is best for them. However, there's this shift, and we call it a left shift in the NHS, where you have this partnership between the person or the people within your room and then the practitioner. And the child or the family, they're the experts in what the child or the family is experiencing because of the child's presentation. And then we have the practitioner, who is also an expert, but an expert in helping with these concerns as well. And together, through what we call a shared decision-making process, a care plan is formed, which is hopefully everyone is in mutual agreement on a way forwards. We probably think as well that we already do this, but the research has been consistently saying over the last 20 years that we're not doing it enough, and even if we think we are doing it well, we could always do it better as well. So moving on, I call this the textbook Podiatry, and it was certainly the way I was taught 20 years ago, with these wonderful books down at the bottom. And it's all about, we would assess what's going on physically with that person in front of you, and then we would diagnose a condition, and then we would have this treatment, and it was listed out within these books. If you go back to them, it's all listed. But what we're finding is that when you start treating people as a whole person, you realise that this kind of approach isn't actually that simple, and it's not actually that practical, and it probably doesn't work as well as you would like it to. It's interesting because as much as we feel that we do have person-centred approaches, I find it fascinating that I'm looking at posts on Facebook. There's a lot of facts about, this assessment and all the biomechanical findings, if you like. But sometimes few comments are made about the goals of what the child or the family would like from an appointment. And I would perhaps like to start seeing that more, because we do also like to jump in with, oh, well, that needs referring on, or if you check the hips. And even these statements in themselves, it's like, well, really we should be thinking about, well, what is right for the family? What would they like? We can see this lack of child and family centeredness within the referrals that we see as well. So these is an awful referral, but flat feet, please see. It's very focused on the actual. It's focused on the body and not actually the human owning these feet, and what are they experiencing. It's interesting because some people would turn this referral around and say, I would only want to know if it was symptomatic. But I think perhaps we should start encouraging referrals more through, what is it that the child or the family would like from this appointment, and do we have their consent? Is it something that they would like to explore? Is it a concern for them? Because certainly in paediatrics as well, we tend to find that referrals are made sometimes without their agreement, or whether it's happening at the right time for that child. Sometimes we can have many appointments, and this is one of many, and it doesn't rate highly in, or rank highly in whether it's important or not at that time. They might be under rheumatology or neurology, and sometimes one of our referrals is quite like low priority. And in turn, sometimes you find that they've not got full engagement as well when they attend these appointments. So it's really important as well that we do reflect what it is that the child or the family want from a referral, and what the benefits are. So I hope you now realise that it's what's in it for me, and this is all about putting patients right at the centre of the decisions that are made about their care, and it happens right at referral, but it also goes on through right to the end of treatment as well. So goal-based care. So this person-centred care, I'm going to call it person-centred, it's shorter to use, it's a precursor for goal-based care. And I think a lot of people don't really feel that they do goal-based care. And I think we need to change our understanding. We probably do, but it's also just recognising it. And I just want to say at this point, Kylie did a brilliant presentation on goal-based care on the Glasgow branch, so please do go see that if you missed out on it. So we do goal-based care. And I think if you are someone who asks questions like, what would you like from our time together today? Or, we have your referral here, but I'd like to hear in your own words, what you would like us to help you with. Or you might want to put it in a timed position, we have 30 minutes today. What is it that you would like to gain from today? This is all goal-based care, okay? We may not be saying that it's like a SMART goal or anything like that. It's not as blatant as that. It's just opening a conversation and opening it up so that you're not leading them down a particular path. It's just open it up, and we'll understand why in a second. What we want to avoid, though, is paternalism, which is, if you remember before, it's that triangle. And it's like, what can I do for you today? Or perhaps, what can I fix? And if we just remember, it's a little bit creepy, and we should move away from it. We should move more around giving them the choice of what they would want from that appointment. After all, it is their appointment, not ours. So I'm going to say that, assuming that there are no zebras, so we've done our assessment and there's no red flags, okay? And I love this, seriously, Barry, if you don't find somewhere new, I'm going to stop playing hide and seek with you. And really what I'm saying here is that I would like people to perhaps at this point think, are we concentrating too much on the impairments of children? And are we thinking enough about the whole child and how they fit in the context of the family as well? So when children and families, they come into your clinic, you're asking, well, what's important to you? What is it that you want to gain from this appointment? And we just say that Barry's over in this is the zebra, by the way, he's over in the body structure and function. And it's obviously important that we look at that and we resolve any issues there. But what's really important for the child is that, what's the impact of their condition on them? And usually children will be more bothered about their activities and how it affects their social interaction. It might be making them feel sad. So it's good to explore at this point, well, if it is affecting your activities, let's pretend you have pain. Is it coming on at the first 5 minutes of play? Is it, after you've finished playing and the pain's really bad afterwards and you can't walk afterwards? So you're just trying to build a picture of, how significant is this issue, and what are certain things that we might need to work on? And certainly from an occupational therapist perspective, they're always more keen to look at the activity and participation because they place higher value on it. And it's certainly where commissioners will place quite a lot of value too. Now, the next thing is what influences some of this? And we have to recognise that as much as you can have pain, it affects your activity and your participation. There are certain personal factors or environmental factors that can impact on this child as well. Okay, so it might be that they live in a separated family, so they might live with dad one half of the week and mum the rest. They might not have great communication between the two, and that means that if you're giving certain care, it may not get communicated between the two. So you might give some orthoses, and for some reason those orthoses can't travel between the two houses, and they request new ones. It may be that they're fed different foods, and they get fed extremely healthy things, but when they go to the other house, they get fed takeaways. That person's really busy, or they might be doing it to treat the child because they're trying to get some one-upmanship, if you like. And that can cause issues with your care. Let's say if that child had a higher BMI, and you felt that it would be helpful for certain health behaviours to change, it's how you communicate those, and it impacts on things. It might be that a child is living in a high-rise tower block and they're not actually getting a lot of ability to go out and play. Perhaps there is no sort of safe outdoor space. It may be that they're from a low-income family, and some of the things that you might want to suggest, like, I don't know, attending a sports club or going to the soccer play, they may not have the money to do that. So I think when you're thinking about your treatment plans, you have to think about the personal factors and the environment that they live in, because it all plays a part on what is right for that child. And really, by opening up the questions to start with, and being open and making a comfortable environment, you can start to understand a little bit more about that child and the family. It also goes in terms of when you have appointments as well. We talk about appointment burden. They may be losing out on a lot of school, or a sibling may not be getting as much attention because they're having to attend appointments for their other sibling. So we've always got to think about the impact of the care and what we're suggesting. They might have busy lives, and you suggesting an exercise program is perhaps just a little bit too much for them. So what I'm saying here is that when we're thinking about person-centred care, this algorithm of assessment, diagnosis and treatment doesn't quite work in the right way. So we need to start opening up conversations. And when we're opening up these conversations, the next bit is that what we have to remember is that what is important to a person is probably quite different to what is important for you as a clinician. And one of the first things that I discovered when seeing this is that certainly children and families are really not bothered about the evidence base, and this evidence base goes right down to where the facts are, and nobody's interested about those kind of things. They're interested about, the values and those motivational roots and the beliefs, and it's really important when you're when I say interviewing within your assessment, that you're listening out for these things, because these are going to be the drivers as to where you plan your care. And I'll go through that a little bit on a different slide. So when you're looking about things that they value, and these are the things that you're picking up in conversations, to, well, what brings you here? Why, what is it that you value? What do you believe is the cause of this issue? Might be that, it's good health, though that's something that they might value, or they might come from a family that's keen on the gym and it's good strength and fitness. Others, they might be, I really value knowing about this condition. So that might mean that you've got to really work on some of the education around a particular condition. There's somewhere children might be tripping and falling, and you're trying to suss out, well, what is it that I need to help them with here? And you might strike a little bit of a chord, because actually they just want to keep the child safe. So some of your advice might be more going down the safety route and how you keep them safe. It might be asking them to slow down, or holding the hand, or letting them play on softer surfaces. And others are just simply coming because they just would like you to check things, and at least if something does change, they would like someone to contact because they've built that trust with you. And other people, they might value the cosmetic appearance of something. And these people, you tend to want to work on more visual cues. So let's say if you've got a child who is in-toeing, they may find value in doing exercises where the feet are more abducted or strengthening into abduction, because it's something that they visually see and they gain more from it. And similarly, we've put this picture of this arched foot. If somebody likes the appearance of a high arched foot, it seems to be that if you give exercises that emulate the arched foot, they're probably going to buy that advice more. So always tap into that. What is it that they value? Okay, because this is more important than, well, if I strengthen this will make it better. They're not bothered about that. It's got to fit more with what they value. The next thing is that you might have to understand what they believe about a situation. So they might believe that you are the centre of the care and that you will fix something. They might believe that if you could do something, you could do it passively, let's say with an orthosis, because something passive is easier. So they believe that that is best. Some people actually might believe that it's a cure, or that the pain will go away or it will get better by the end of the week with your intervention. Or they might believe that they can get back to performance immediately. And with these, you have to start these conversations about realistic expectations. They might believe that orthosis prevents something, or that they might believe that casting are better. And with these, you have to ease them gently into the conversation, that it might not actually be that way. It might be that you want to focus a little bit more on the positives of footwear and how that can work very similar to orthosis. So it's sort of tailoring your communication to match with their values and their beliefs. I was putting this one in. I'll never forget. There was a child that came in with genivalgum, and I was drafted in for that second opinion or voice because they didn't believe that genivalgum was part of normal variance. And in the end, I had to pull it up on Google. And don't underestimate it, because as soon as they saw this, it was just like, oh, well, if it's on Google, it must be true. And it kind of made me chuckle, really, because, you know, we had two clinicians and we said, no, this is as it should be. And no, didn't absolutely believe it. But understanding some of their beliefs behind it, it was a very strong belief. They believed that this child, when born, had an antibiotic overdose, and they felt that that had led to deformities within the body as a consequence. It wasn't the case, but it's just an example of how a belief can be far from the truth, and sometimes you have to demystify it and find things that people can relate to, or sometimes things that people trust. And it's interesting what people do trust. I mean, we trust evidence-based, but it's not always the first thing that a parent will go to if they want to understand whether something's right or not. What I would like to bring up at this point is that sometimes people see patient-centred care as people getting their own way and things running out of control, but it's still okay for you as a practitioner to set boundaries. And I think you have to be quite clear about what you will say yes to, and this has to be according to your priorities and values. So, for instance, I'm quite happy to say that I'm happy to provide orthosis, but I'll be a bit reluctant to do that if the child is asymptomatic and not having any functional concerns, and that's when I'm quite happy to say no, I will not go to this point. And it's important that you express these boundaries and you don't let people cross them. And I think it's important because you're actually being kind by doing this as well, both to yourself and to them. And just give explanations that are relevant to the person as to why that is. And when you're setting a boundary, you must be willing also to accept that you may not get what you want, and that might be that the person may not go away thinking, "Oh, that was great," or "I'm happy with what we said." I think it's important you do set your own boundaries according to your priorities and values. Moving on. So, compliance, dirty word. we like to move away from that. It's not very person-centered. We hear this, we've heard it before. It's like, they didn't even do what I asked them to do. And I think when these things start to happen, we have to ask ourselves, you know, did we take on a person-centered approach? Did they actually agree to what we suggested as part of their treatment plan? Before I explore that a bit more, I just also want to talk about health literacy quite briefly. It's quite an interesting fact that about 40% of the population are what we call, they've got health literacy challenges, okay? So some of those might be people aren't sure when to access care, they're not sure which agencies provide care. It may be even that people might not know that there's bones in the foot, or there's pulses to feel in the foot, or that forces cause deformity, or muscles are responsible for movement and strength and power. Health literacy rises to about 60% as soon as you start adding numbers to that. So whether it's the dosing of medication, or you're talking about the number of times that they have to do a stretching exercise, whatever, yeah, then all of a sudden that health literacy declines. Okay, so we have to be quite mindful of what people might already understand about a condition. Okay, so sometimes we might say, I'm going to give you a strengthening program to help X, and they can't relate to it because they don't actually have an understanding of anatomy. Okay, so just to be mindful of that. So when we're talking about, and we're going to call it adherence or concordance. Concordance means that they come to agreement and they're happy to go ahead with it. And adherence is more just following the advice. Okay. Now, for some people, we have this, what we call non-intentional non-adherence. And this is simply because there's been a misunderstanding. And it might be that the treatment was overly complex, or it lacked routine or prompts. So this goes back to this health literacy, as sometimes it might have been too much to process. Okay. So some of the solutions when we're looking at this is that we might want to tailor that education, and it's all about really understanding that person's perspective of what is it that they understand about their condition, and how might I have to tailor my communication so that they've got a better understanding. Might mean that we simplify the treatment, or we might need some sort of reminder system, or we might want to combine it with some daily activities like brushing your teeth. So it might be, do you want to do your strengthening exercises while you're brushing your teeth? Might that fit? Or you could turn it around and say, well, you know, we were thinking we could give you these exercises. When do you think you could do them? And then it gives them a little chance to think, well, actually, I could do it at this point of the day, perhaps before my homework. That would work for me. Okay, so it's good just to turn that around. So examples of simplifying care might mean that they're not getting the left and the right, in the right way around. Might mean you put stickers in the shoes. It might mean that you use the orthosis, the blue and red, so they understand the difference between left and right, or you actually write left and right on the orthosis. If you're into stretching, it might mean that you give them a stretch board. Instead of doing a complicated 1 foot forward, the other foot back. Simplifying care might also just be, if you're watching television, do you think you could do it then? And then there's no additional task to be had. Or it might be that you give them something like a wobble cushion instead of some fancy foot strengthening exercises. Or instead of giving them a whole raft of exercises on a sheet, just give them 1 or 2. Okay. Pick the most important and then keep building on it from there. For some children, and it's usually more for those children on the spectrum, is that visual schedules can be quite helpful in the sense that they might use them already, and you might just have your own little extra bit that you pop on that schedule, and it's something that they can come to terms with a little bit more. Certainly if you're trying something new or you're deviating from their routine. Okay, I'm just talking about that routine as well, just to reiterate, do it at times when it's something that happens every day, so it might be brushing your teeth, etc. Also, you know, that person-centeredness is about tailoring and understanding that there's certain personal factors that mean that children need help in a slightly different way as well. So it might be that you have to demonstrate a task, as we call hand over hand, and I usually do this is the first one. So you stand around the back and you put your hands where their hands are, and you might be holding some TheraBand, and you do the exercise together, and it's more likely to be understood. Or it might be that I sit on the plinth next to them and we do an exercise together. Let's say it might be a knee extension, because you're showing it from their perspective and they might understand that better. Or it might be that you give them foot placement markers, or it might be that you get them to do their exercises in front of the mirror so they get that visual feedback. So with all of this, it's just about tailoring your care so that children can undertake the tasks that you've come to agreement on doing. So then we have this we call intentional non-adherence, and this happens when your recommendations are not compelling, okay, or there's a lack of motivation to follow that advice, or there's some deep belief that it will conflict with guidance. And when you have these situations, I think it's a case of use a very different approach. So it's either shared decision making, motivational interviewing, coaching, the kind of techniques. You want to understand a bit more. There are obviously courses out there, but a lot of them follow this T-GROW model, where it's what the goal is, where they are now, what the options are, and then sort of wrapping it up and talking about the support that they need. So coming to a close, I think that perhaps the main thing that we want to take from this is that make a connection with what people want. And I've added this because I think people are sometimes successful because they can make a connection with someone and people actually understand where they're coming from. Even let's say whether you love it or hate it, the Daily Mail is very good at communicating on that level that people understand. So if you take anything away from it, connect with what people want and what people need. Okay? And if you haven't seen Sarah Cooper, she's someone who has cheered me up this lockdown. So do check her out on Twitter. So just to round up, child and family centred care. It's all about working in partnership. So just remember, it's no hierarchy. You're working with them on a level ground. They're an expert, you're an expert, and together with shared decision making, you can come to agreements on what is right and what would work. You should appreciate people's individuality, and a lot of that comes down to what makes that person, where they live, what their certain personality or characteristics are. It's really important that you understand their beliefs and their values, because if you don't fully understand them, you could go off down a track of giving them a list of treatment that is just not going to sail. Okay, and think about concordance. Okay, it should happen because you've come to that shared decision as to what's right. And essentially, if it doesn't go right, it's either unintentional or intentional. And if it's intentional, when you need to go back to the beliefs and values of that family. So tailor your care. So I hope you found that helpful, and I'll catch up with you later. Okay, thank you.
Hi, I am Dr. Helen Bamwell, a lecturer at the University of South Australia, and I'm here to talk about the use of foot orthotics in a paediatric population. Now, can I say straight off the bat, when I talk about paediatrics or flat feet, what I'm really meaning is that a flexible flat foot presentation, and I need to be really clear on that I'm not talking about those, rigid populations that can be really problematic for children and generally require surgery. I will put some contacts up the end, but please note that I'm at the University of South Australia, and if you need to find me, that's a really good place to start. So what we're going to cover are things like flat feet, what do we currently know? And that's just going to be a really brief overview of what, of the literature, and then a bit of an update on the evidence for the use of foot orthotics in this particular population. And then I'm going to finish with some work that we did a year or so ago, looking at when, why, and how we should be prescribing orthotics to children with flexible flat feet. And we'll just discuss that a little bit further. So I always am very conscious that I do not work alone. All of the information that I'm going to share tonight comes from a wide and varied group of people. I've listed a few there. I'm probably going to mention more than I've listed there. I forget a few. You'll note Dr. Kylie Williams is on there because I don't think you can do any paediatric work in Australia and not involve Kylie because she's such a good resource, but also Angela Evans, and I'll talk a lot about her population data as we go through. The other colleagues that are listed there are all at the University of South Australia with me if you're trying to hunt them down as well. So flat feet, what do we know? Is really frighteningly that flat feet is one of the major reasons that people take their children to see an orthopaedic surgery or an orthopaedic service. So in the NHS or in the private or public sector over here, what we find is anywhere up to 30 to 40% of an orthopaedics workload or an orthopaedic services workload is around the presentation of flat feet. What's fascinating is, the body, if you look at the body, the feet probably take up about 10% of the surface volume, but taking up that much time. So we are really aware that this is still a contentious issue, particularly for parents and carers. They're highly concerned. We also know that from 2 audits that we've done here in Australia, one in Queensland and one here in South Australia, that over 50% of the presentations to a podiatry clinic, regardless of what they present for, have got a measurable flat foot posture when we look at it. So Queensland audited it quite a few years ago. I think it was 1998 or something. We audited it a couple of years ago, but it was, highly consistent between our adult and our children's clinics that 53% and 52%, to be exact, respectively, of adults and children that arrived had flat feet. What was also sad is they were likely to have pain as well. We know with flat feet that there is no relation to body mass, and that contradicts a bit of information that's been out there for a long time. For those that are, dinosaurs and trained back in the 90s like I did, that was pretty much standard part of the course, was that kids that were heavier were going to have more flat feet. And of course now we realise that was just, we were measuring it using footprint indices. So we were getting these children with, more adipose tissue around their feet and getting them onto pieces of paper, tracing around them and wondering why they were all measuring as flatter, when in actual fact, the structural wasn't altering as much. So when we use something like the foot posture index, which gives us a little bit more of a 3D thought about the foot, we find that doesn't ring true at all, that there is no correlation between weight and flatness. And it's been good that that's been put to bed, because that's been a bit of a contention of mine for quite a few years. We do still see, regardless of how we measure it, that males are more likely, not far more, but more likely to be affected than women. The girls, sorry, they are children we're talking about, so girls. And the good statistics that measure well tend to put the prevalence of flat foot within the population somewhere between that sort of 23 to 44%. A few ethnicity changes and population changes, but somewhere between that quarter to 45-50%. However, the prevalence, because of the way that we measure it, is so broadly, sort of reported in the literature. Literally, you can get it saying that we've only got you know, 0.6% of our population presenting with a flat foot type, all the way up to nearly 80%. So it's always a bit of a caution to me, and I'm a lecturer, so I taught, you know, I teach the students. It's always a caution from me to say, really have a good look when you're reading any population data or any studies on flat foot. Please be mindful of how they've measured it. What we also know is that flexible flat feet in children is completely normal. It's quite normal in typically developing children, and that flatness reduces, as we know, that flatness reduces across the first decade of life. And it's purely about these are developing, you know, sort of complex structures, and just that interplay means that they're not quite as arched as what adults are as yet. So that raises the question, if it is a typical finding in children, should we even care? And it's a controversial point that, you know, working in this area, I've had people sort of, the naysayers tell me that it's, you know, benign neglect to leave them alone, whereas it's also often sprouted as, you know, sort of almost child abuse to intervene if it's a normal finding. What we do know is that children with symptoms of flat feet are statistically significantly more likely to walk a lot slower than their peers, and that has a few implications for development. They have poorer performance in lower limb specific tasks, things like jumping and long distance and running. They have a lower quality of life in some cases, particularly in the physical domains. And again, these are only statistically significant differences. And they certainly have an increase in hip, knee, and back pain presentations. There's also the consideration that as adults, we have an increase in back, knee, and pain presentations. And one of the studies that I often come back to is there was a study done by Kosheville, the very last one there, that was in the Israeli army. And the reason I come back to this study is because its N size, its sample size was 97,000 people. And they're numbers that for researchers like me, I'm never going to have a study that's even remotely close to that. So what they did is they looked at their army recruits from beginning and end of their equivalent of a boot camp. So the first early weeks of boot camp. And their measure of flat foot was, I'll be kind and say arbitrary, but in a sample size that big, they divided it into normal, high arched, normal, mild flat foot, moderate flat foot, and severe flat foot based on a measure that they came up with. Now, I'm not quietly confident that they got all of that right, but I am confident in a sample size that big that they could pretty much pick out the severe and maybe even the moderate flat foots, you know, with all that training. So what they found is that women in particular with flat feet were going to have 7 times more likely to have back pain and 10 times more likely to have knee pain. And the men weren't far behind. So this was a group of really healthy, very young, you know, it's you know, sort of mandatory, for want of a better word, service there. So if you take a group of these, you know, these people aged between 18 and 22 years, and you force them into quite a stressful, physically loaded situation, to find that those with flat feet come up with almost 10 times more likely to have back pain and knee pain, that scares me. So, you know, obviously I think there are times where we do need to just consider what happens if we do not intervene. So if we are going to intervene, what are we going to intervene with? And for us as podiatrists, well, then our take-home intervention has always foot orthoses. We know it's the most common one that we as podiatrists, you know, tend to use. And I've audited podiatry practices, and that's what the evidence tells us. So if it is foot orthotics, when and how do we do it? And should we be doing it? So as a bit of an update on the evidence, and I can't remember exactly when this came out. I'm searching madly for the date on this. I want to say, what's 2018? So 2 years old now. But this was a systematic review that was an update to a previous versions of the systematic review. So what we did with this one, and Sindrani Das, who was one of my honour students, who's now a colleague at the university, Sindrani looked at just for the last 5 years, so from 2017 through back to 2011, which was the last, at the time, that had been the last systematic review published. So 2011, and we went through to 2017, so update on a previous systematic review. The previous, what they'd found is in 2010, there were 3 RCTs, and in the hierarchy of evidence, randomised control trials give us our best evidence. So out of those 3 RCTs, and we'll talk a bit more about them in a minute, only one of them had a significant positive outcome. And that basically said that you can use a flange device, so a medial lateral flange device, otherwise known as a UCBL device, University of California Biomechanical Laboratory device, in a paediatric population that had painful inflammatory arthritis. The other 2 RCTs were in non-symptomatic cohorts, and what they found, there was very little difference between the 2 cohorts. There wasn't a significant difference between the 2 cohorts. But remember what I said about it being a non-symptomatic version. In 2011, there was another review put out, and that had 13 studies, including the 3 RCTs above. And in 2012, there was another systematic review put out, and that had 18 studies, including those 3 RCTs. So no more RCTs. They were all clinical or lesser evidence type interventions where you measure somebody at baseline and then you intervene and you measure them again. So, repeated measure tests. So good to get you some evidence, but not as good as a randomized control trial. So when we updated, we found another 11. So between 2011 and 2018, there had been 11 studies conducted, including 3 new RCTs. So we doubled our number of RCTs, or high-level evidence. So what the update found, and I've done a bit of a trick here, in green ticks means it was a positive significant improvement in that area. The amber ticks means that it was a positive result, but not a significant. They got better, but not to the point where you can say it's a statistically significant outcome. And of course, the cross was a negative effect. And the only cross that we found, so the only thing that we found that went backwards was actually on navicular height. And I thought that was a bit weird, that one. It was purely a kinetic measure, but what they found was that that particular cohort, from start to finish, had a navicular drop. Everything else was positive. And that's a good take-home message in itself. But let's look closely at those RCTs, knowing that they're our highest level of evidence. So what I've done here is the 3 RCTs in the green are the ones that were included in the update. The amber ones were the ones from the original studies that we talked about, where I said only one of them had got a positive result. So what excites me about this is, if you have a look at that top row, this is the outcome for pain. Now, as a clinician, I work predominantly in children. I work with a disability service. I teach a paediatrics clinic. For me, I hear pain and fatigue more than any other symptom. So when I see studies that are in a symptomatic cohort looking at pain, I get quite excited, because I think clinically that's the most relevant outcome that we can measure. So if we have a look at that top row, what we're seeing is that we've got 5 out of the 6 studies that actually measured pain, and we've got a statistically significant reduction in pain for 3 of them, and a positive in all of them. And that's my hallelujah moment, where you go, we're actually getting some really lovely evidence to suggest that what we do, and what we've been doing for many, many years, may be of value in this particular population. And you can see the other measures haven't been so broadly studied. And again, I see that as a positive. I see that we're less concerned nowadays about X-ray measures, kinetic measures, and actual foot posture, and we're more concerned about the pain and the functional outcomes and what happens in gait. And I see this as very much our research growing up and becoming a little bit more relevant to our clinical practice. So that boils down to, does this mean we have carte blanche? Should we be prescribing orthotics for every child that walks in the door? And no, that's not what I'm saying at all. Please don't quote me saying that. But what it means is that we probably need to have a really good case behind us when we're going to intervene. Because remember, I said 2 out of those 3 original RCTs looked at a non-symptomatic population and got no change between those that got orthotics and those that were in the control group. So just, sort of carte blanche prescribing orthoses for every child that walks in the door with a foot posture, outside of the exact range is not necessarily the way to go. But when they present with symptoms, I think we've got a little bit more justification now, and that's a great thing. So how do we do it? There's a form for that. Sindrani Das, who was our podiatry honour student extraordinaire, put together a form about when, why and how we should look at paediatric or the use of foot orthotics in paediatric populations. And what this was based on, and this is shameless plug number one, and there was going to be another just quietly, but this was based on some work that I did as a PhD student in adults. So for those that don't know about this, I use this all the time in teaching, and I know it's used quite regularly in teaching. But what I did as a PhD student was looked at how we should be prescribing orthotics, not so much for when, but how, and came up with, I did a Delphi survey where I got experts from around Australia, and we had 20 odd on the panel, and we looked at when do you use all of the individual variables that are associated with, you know, the literal prescription of foot orthotics. So things like when do we use a neutral or an inverted cast paw, and we found that surprisingly there was a lot of consistency within our prescription habits than what I was expecting. I was a bit nervous when I went in to do this survey thinking, oh, you know, what if we find that we all do our own thing and there's absolutely no consistency between us as practitioners. And that scared me because that makes us more artists than scientists. And I wanted to see some, you know, some sort of consistency, and I was incredibly pleased to find this. So the foot prop, the way that this has worked is that we got all of the people, so 21 podiatrists, we asked them when to use a neutral paw, only in flat-footed people, when to use an inverted paw, and so on for all the variables that you can see there. So a medial flange, your forefoot posting, any accommodations, all of that kind of stuff. And then we took their reasoning and we sent it back to them over a series of rounds and got them to rate their agreement to it. And what this document represents is for any sort of rational or rationale for use that 70% or more of the panel agreed on. So things like, you know, if you've got a subtalar joint that is really medially deviated, you may want to invert the paw. And I read through this list even now, I read through this list even now, and I think they're really sensible suggestions. And of course, the students, our biomechanics students, when they're looking to prescribe for a flat foot person, they love this because it's a bit of a cheat sheet. But the other thing, and while I'm on the shameless plug, is we also did an audit of how we prescribed in the podiatry clinic at the university. So, you know, we have over 4,000 occasions of service across a year, but still one clinic. So, you know, caution when we talk about these results being sort of groundbreaking, because they're based on one clinic and one clinic only. But what amazed me is I looked at the foot measures that we took and then the prescription that we wrote for it. And we were consistent in that when somebody came with exaggerated or, you know, hypermobility of the rear foot, we were really consistent in inverting the cast to give them a little bit more stability. And when people had other things, we used a medial heel skive when we wanted to decrease pronation. And there was only a couple that we were consistent on, but that, again, I was so pleased to see that as a profession, we actually have rationale behind what we do, and we're consistent, or some consistency behind what we did. So what we decided to do was to try and sort of replicate this without being quite so prescriptive, for want of a better pun, but about when, why, and how we should use foot orthotics in children. So sorry, going backwards there. So the latest work, and again, this came out in 2018, based on the same principle. So this time we looked at people from Australia, UK, and New Zealand, because we're quite similar in the way that we're trained and we assume the way that we practice. And we had this Delphi panel, and we went through 3 or 4 rounds, I can't quite remember now, but looking for reasons for when you look at using orthotics, why you look at using them, and then how you actually prescribe those orthotics. And again, we had some beautiful consistency. So a 3-round Delphi, 15 podiatrists, so smaller panel, but more widespread. Round 1, you ask lots of open-ended questions about when do you do it, why do you do it, and you just let them give you as much information as they want. And in rounds 2 and 3, You send all of that information, so it's all anonymous, nobody knows who each other are, but you send it all back to them and they rate their agreement to the statements. And what we ended up with was 83 statements where people had agreed. And again, we set agreement and consensus at 70%. So it wasn't just a majority rules, it was 70% of the panel had to agree for us to accept that statement as a practice point. We had a few different people from different backgrounds. So we wanted a couple of people from academia, but we also wanted people that taught. So that was the reason we sought academia people, only a couple. We had a lot of people that worked solely in children, and we had a few that worked across the board. We also had, again, just a couple of people that have researched. So on average, we had more males than females, which kind of flies in the face that women are in peds more than men. Their average age was 40 years and their average experience was 17 years. So quite a cohesive and, dare I say, experienced group. 21 consensus statements right off the bat. So, and that's an amazing outcome. So if I just asked, all of you that are watching, just to give me five or 6 points about when you would, when, why and how you would prescribe foot orthotics for flat feet, for you to come up with 21 consistent things that 70% of you say is just fantastic. It means that we really are, we may not all be on the exact same page, but gee, we're in the same book. And that's brilliant. Delphi round, again, rate your agreement to it. So out of the second round, we got 44 statements, and out of the third round, we got 18 statements. So 83 statements in the end. And from that, we were able to produce this beautiful clinical protocol. So I'm just trying to move myself out the way, but we're going to look at this protocol by section. So our first section was, I'm right in the middle of it, aren't I? There we go. Was how do we confirm a diagnosis of flat foot? And I was really pleased to see that the foot posture score, or the foot posture index, was the one of choice. Failing that, people looked at rear foot calcaneal and neutral calcaneal and the difference between them. And a bit of an old school measure, but certainly one that it's still my go-to. And it's clearly other people's go-to too. So I felt better about that. But as I say, really pleased about that foot posture index. Then we looked at the signs and symptoms, and I was again really excited to see that a lot of these are based around signs, but symptoms and function, which is, as I say, we're growing up, or our research is growing up to catch up with our clinical practice, because I think this is how most of us practice, in that we look for, is it a propulsive gait? What are the gait abnormalities? Do they have limits in what they can and cannot do? Do they have an affection function? I still get all of my kids to try and do a single leg stance and let's check their balance. What other things are going on with them? And you can see that these signs and symptoms are really broad and I think all encompassing. And it's not to say that if it's not on there, you don't do it, but as a sort of an expert consensus document, I think this gives us a really lovely justification for kind of going, well, I am going to intervene here because a panel of my peers that are quite good in this area are telling me that poor endurance and balance is an issue associated with flat feet, and it's something that we could potentially intervene in. So again, I'm not going to read all of that out because you can do that yourself, but I use this list all the time, and I use this with parents. I used it last Tuesday with a beautiful mother that had come in with her absolute, I'm still mesmerized by her 3-year-old. She was such a little feisty kid, and her mother and I spent a lot of time on this form kind of going, what do you see? And this child has some cerebral palsy, some cerebral, this child, was like being, that's a terrible thing to say, it's like being slightly pregnant. You either are or you aren't. This child has cerebral palsy and has some effect on her gait, is what I meant to say at the moment. And it was really, I think comforting for mum to go through and actually look at this and go, oh gosh, okay, children with flat feet regardless will have activity limitations and all that kind of stuff. And for her to be able to pick out the things that were going on. Now, we didn't get into all the neurological stuff. She's got her pediatrician on board. Everything's happening the way that it can. But it was really nice for her to be able to sit there and go through those symptoms with me and pick out the ones that she thought were a concern. That excessive tripping came in very handy. This little girl tripped constantly. And lastly, but certainly not least, if we are going to intervene, what are we going to do and how are we going to do that? So in that right-hand column, you can see that we've got alternative or additional interventions to foot orthoses, because again, I think most of us we're not a one-stop shop. We don't throw some inserts at them and run away. We talk about other things that are important. So I'll leave you to read that. But looking over at the intervention, prefabricated orthoses, the way to go. If you've got a fit that will, adequate fit to the shoe and adequate control, why would you not look at a prefabricated orthotic? The only time that we found that customised orthoses were, from our panel's agreement, was that if those prefabricated devices just weren't adequately controlling the issue, or if there was another issue that could not be fitted in a prefabricated device. And you can see there that what they're talking about is you can do a neutral or a vertical cast paw with minimal arch fill, and you can use a medial curvy heel sky for severe frontal plane disorder, the same as what happened in the adults, I might say, and that UCBL or high flanged medial and lateral flange device for severe pes planus, particularly in those transverse pes planus presentations where you're really struggling, to not keep them sliding off their orthotics, but also, sliding around in those shoes. And of course, a medial flange, just a one-sided flange, when you need that bit of extra midfoot control. So from my perspective, this was a really sensible, document. And as I say, we use it all the time in teaching, and I use it all the time in practice. But I think it gives us a bit of a basis. Now, it's evidence-based, and I'm going to put the really large disclaimer here. This is not evidence-based. This is, expert opinion-based, or opinion-based nonetheless. But I think it is a nice little starting point for us. And our job as researchers from this point forward is to go on and try and make the long-term links between, if we see these signs and symptoms and we do intervene, what benefit do we have in the long term? And that's, where I think a lot of us are heading or looking to head, to try and work out where do we sit, in resolving these issues as time goes on. Bit of a challenge for us going forward. So basically, at the end of the day, we've done a lot of work and a lot of data collecting and a lot of surveys and a lot of writing and a lot of research to basically tell you that you just need to carry on in your way of assessing your beautiful children and intervening when required. I think the take-home messages for me though are that the evidence for using foot orthotics is increasing. We are catching up with clinical practice a little bit. We have far more consistency in this profession than I ever thought possible, and that thrills me no end. And where possible, we continue to use a prefabricated orthotic if we can. And that's about it for me. There's a couple of really helpful reads there, and the one that I forgot to put in, but the one that I think is really important is, now Angela Evans is an author on it, but I can't remember the main author's name, but it's around the population data. It's the big population study looking at what is a standard measure using the foot posture index for children from birth to 12 years of age. A bit of a deficit in those really young children, but otherwise an incredibly strong population data set. And what they've done from that, and what Angela herself has done from that, is produce a ready retina. So if you go on to Angela Evans, podiatrist, ready retina, Google, it will come up with her ready retina. And what it does is it shows you your sort of one standard deviation for foot posture using the foot posture index, and then your two standard deviations either side. So again, you can do your measures of your foot posture index, take a note, use the ready retina to show parents or to show carers where the child is sitting on the population data. And again, that just gives us a little bit of evidence behind our diagnosis, if nothing else, of it being a flat foot as opposed to it being a typically presenting foot that is flat because it's okay at that age. And that, to me, that's a brilliant way of differentiating between yes, it's a flat foot, as it should be, versus, yes, it's a flat foot and it's more flatter than we expect at this age. So again, we've got it printed off in the clinics so that I don't have to keep going to the computer and show people, but a really easy thing to Google and just bookmark yourself at home. So contacts, I am on Twitter. I tend to push out a lot of our research through Twitter, and and retweet things that are, I think, exciting or relevant in the paediatric world. So please feel free to follow me. And that's my email in case you want to email me any questions. And the caveat to that is, if you're currently one of my students, please don't send me an email asking yet again what's going to be in the exam in the next 2 weeks, because I won't tell you. All right, I hope you found that helpful, or at least informative, and please, by all means, give me a call or get in contact if there's anything that I can help you with. And good luck for the rest of it. Look forward to seeing you all in a more virtual, but still virtual, but a bigger setting come next year. Thank you.
Welcome. My name is Simon Jones and I chair the Children's Podiatry Special Advisory Group. I'd like to welcome you to this morning's conference and thank you very much for staying to this point. At least you've not gone off and got a coffee or gone for a lie down if it's sunny, so that's really good. I'm going to try and entertain you for the next 20-25 minutes with a topic that came to my attention probably about 3, 4, 5 years ago now, but it's really come to the forefront recently and there's been a lot more press around it, so I was asked to revisit it and had a look at it again, and I'm now going to present it to you this morning. I worked in the health service for approximately 32 years, and then about a year ago I moved out of it into the relative domain of private podiatry, private practice, and I now work at a practice called Falcon Yard Podiatry based in Chesterfield in the High Peak, which is a beautiful place to work, very pretty little market town, very pleasant, and slightly different to the NHS. It's not good, it's not worse, it's just different. So moving on, what I'm going to do this morning, you've been sat there for a little while now, is I'm going to just get your brains thinking a little bit with a little bit of a quiz. Now there are right answers, but I'm not going to give you them. What I want you to do is have a think about it and then go away and compare your answers to the ones that you found and see if you're surprised a bit about them. So let's have a think about it this morning. So what is the average age a child sits up? We're talking averages here, and we've obviously got parameters and differences and variables. But if we take an average child, what would that age be that they actually sat up? And what is the average child in 2013? So we are talking 7 years ago now. What would be the average child, the age a child actually walks? Looking back, so 10 years earlier, that was 2003, an interesting comparison would be, is this earlier or is it later than 10 years before that? So in 2003, would a child walk earlier or later than in 2013? And if you think about the variables and the parameters, why that might be the case. How many steps a day would the average 13-year-old take today? So obviously for the last few weeks it's been slightly strange because I would suspect that the 13-year-old is now taking substantially more steps, but during the normal life that we lead, not in these strange times, what would be the average amount of steps a 13-year-old would take? And how many steps would an 18-year-old take? Taking into account all the factors, they may be at school, they may be at college, they may be at uni. How many steps would you say they then try and undertake in a day? Move into more recommendations. What's the recommended amount of a moderate or vigorous activity per day for a 5 to 18-year-old? The World Health Organization splits the recommended activities down to age groups, and one of their main age categories is 5 to 18 years old. So what would be the recommended amount of activity for that group? This one has always perplexed me. I have 2 daughters who are getting on the older side now, but they still engage in this. And I was trying to think back, and at what age do girls start to like shopping? My guess would be around 2 years of age, when you start seeing those Zara bags, the H&M bags, and the Primark bags starting to appear in your hallway, and those card swipes are starting to go onto your account. That has made a difference in lockdown where we've not had that, and my bank account has spontaneously improved. However, I do feel it's probably going to take a sharp decline again. Do women or men do the most activity per day in the North East? We're talking physical activity here now, whether people would regard washing up as a physical activity. I do a lot of that, so I do, obviously. But it doesn't seem to be getting rid of the calories on me, so I'm not so sure. Are purchases in the Northwest of fruit in any form, so that could be canned or fresh, increasing or decreasing? And what are the percentage of children consuming 5 portions of fruit or vegetables a day in the Northwest? I'm particularly based around the Northwest, and so I'm very interested in the statistics from the National Statistics Service. Obviously, this came out of Scandinavia and was originally 21 portions. It was then watered down as it came further south, and by the time it got down to Manchester, we'd taken it down to 5 portions. So what percentage do you think are even achieving that? And which gender has a greater hospital admissions rate? Is it male or female with obesity in the Northwest hospitals? Moving on to our realm, podiatry. Are we just podiatrists? Do we just look after feet? You know, the public perception of us with a scalpel and a pair of nail nippers in our hands, we all know that that's slightly undermining. So we need to think about it, especially in terms of children and the realms of where we practice with children. One of our main aims is to look at that. The health of children generally has been acknowledged is deteriorating with increasing obesity, increasing mental illness, and decreasing self-esteem. And we do have a role to play in the improvement in those situations. But what can we do? Where can we help? To start to help, we have to look at the publications that come out, and the 3 main ones that we have looked at in the past are Every Child Matters, the National Service Framework for Children, the NSF, and the documentation called Choosing Health. And they're well worth a quick flick through. If you're bored in an evening and want to go to sleep early, then perhaps a quick flick through, and that might help the job. Have we got any questions so far? Oh, that's good. I can't hear you, so that's brilliant. Obviously, if you've gone to have a coffee, you've gone to have a lie down, or you've left me by now, then see you soon. But hopefully you haven't, and you'll stick with us. One of our main mottos within the Children's Podiatry Group is remembering that children are not young adults. They're not a small down version, they're not cut down, they're completely separate, completely different, and are treated very differently. And that's why we encourage very much a children's service being as a specialist part and not just a bolt-on to MSK services. As I say, my name is Simon Jones, and that's my email. If you want to email me at any point for any questions, or if you want me to contact any of the speakers about anything you have heard today, then please don't hesitate to contact me, or about any of the upcoming events that we have on our agenda. Why did we look at the picture more holistically? A lot of children we see need physiotherapy, and we had a lot on our caseload that needed physiotherapy assessment. There were a lot of children that physio see that needed a podiatric assessment. And children that we see also are seen by physiotherapy, occupational therapy, speech and language therapy, and children's and adult mental health services. They go to many separate appointments with their parents. The parents have to take time off work. The children have to take time off school. And this causes a lot of friction. Also, it causes problems because of interprofessional relationships where you get 2 people having slightly different opinions and the parents become confused. So wherever we can, we now try and work towards joined up appointment, joined up thinking, and cross professional working, which is, as we know, the way forward, and it gives a far better outcome. The topic that I'm going to speak to you mainly about today is one, as I say, came up about 4 or 5 years ago. It reared its head and has just started to come back into the mainframe again. And so I'll revisit it because it's well worth a topic that we can have a chat about. The topic I'm going to talk about is called sodium valproate syndrome and its effects on the child. So sodium valproate would be taken by the parent, the mother. It's not where it's taken by the child. This is specifically one that's passed down from the mother to the child. Sodium valproate is a common medication. It's also known as Epilim or Lept, or in America is pretty commonly known as Epicenter. It's an anticonvulsant, and it's used in the treatment of epilepsy and panic attacks. And more it's starting to be used in the treatment of anxiety, anorexia, migraine, and commonly now bipolar disorder. The difficulty is that because of the stigma of some of the reasons that these used as a treatment, this is now often not brought forward by the parents that they're having it. Or they may well mention the mother that she's epileptic, but she's probably not going to pitch up to you and say that she's anorexic or got bipolar disorder. So as a result, it's worth keeping in the back of your mind that it might be absolutely straightforward apparent what's happening in these scenarios. It is the most commonly used anticonvulsant. It's a very widely used drug. It's very well tolerated by the patient, and it obviously is cheap, which is a bonus for the NHS. So they will tend to use it as much as they can. On a very superficial neurology, the brain and the nerves are obviously made up of many nerve cells, and they communicate by electrical signals. I'm keeping this simple because I am simple. Abnormal and rapid and repetitive signals are always regulated. We don't want to get them out of hand. But when they're abnormal or they're rapid and they're released, it leads to fits or seizures. When those abnormally rapid or excessive signals release to brain, it leads to fits and seizures due to the overstimulation and the disturbances of normal function. And that normal function can then be picked up on functional MRI scans or brain scans. It's also used off license, as I mentioned previously. It's treating bipolar disorder, some psychiatric illnesses, and controlling episodes of mania and some schizophrenia. They're not sure why, and they obviously, like most of these things, stumbled on it, well, pretty much by accident, but they thought it was due to the increased activity of GABA. Sodium valproate increases the production of sodium valproate and prevents breakdown. That should be sodium valproate enzyme. Prevents breakdown, stabilizing electrical activity, and that prevents the fits. It stabilizes activity by preventing sodium entering the nerve cells. Sodium needed to pass on signal is therefore blocked, and so that increase in nerve cell activity is reduced. The sodium valproate prevents epileptic fits by increasing the activity of GABA, and it is a neurotransmitter in the brain which calms nerve activity. The side effects to the mother, the patient, which you may see, and the difficulty, as I say, is that parents are probably not going to be massively upfront about this, is that the mother might come in looking tired with a slight tremor. They might appear to be slightly nauseous. They might vomit if you are unlucky enough to have to clean it up off your clinic floor. They might be slightly sedated, slightly drowsy, and 10% of patients have a reversible hair loss. So 1 in 10 may come in looking slightly less hairy than normal. In pregnancy, the problem is that sodium valproate has the highest risk of birth defects and symptomology than any of the commonly used anti-epilepsy drugs. Some epilepsy can only be controlled by valproate, and seizures obviously have very grave consequences for both the mum and the child. It is a very, very well tolerated drug by the patient who's taking it. And quite commonly you have got the sliding scale of do they take it and the mother is at risk, or do they take it and the child is at risk. It's a very tortuous decision to make. But unfortunately, the risk of birth defects with sodium valproate is 2 to 5 times higher than any other frequently used anti-epileptic drugs. As an absolute, it's 6 to 11%. And all children born with mothers who've taken sodium valproate have an average of 9 points lower IQ. All medications in this range have increased risk, there's no doubt. In fact, all medications per se have a risk. But the most attributed one with the anti-epileptics is spina bifida. But sodium valproate increases these significantly. In a 2005 study, which is probably the most up-to-date so far, although I've heard that one is being taken at the moment in America, a very large cohort study, 8.9% of children whose mothers took sodium valproate have autism. The normal population is gauged to be about less than 1%. A class action lawsuit is currently, and has been going on some time, underway in the UK regarding a claim that the drug used during pregnancy causes autism. learning and social difficulties, with 40% of children that are on the additional educational need register. And 30% have placed a statement that it's now called the Educational Healthcare Plan. It's being phased out throughout the country, and it's not known as statement at very many places now. The Educational Healthcare Plan is an excellent tool and sits with the child until they're 25 years age and looks at both health, education, and social background, and so is a far better way of assessing the child's needs. It's also associated with ADHD and, interestingly enough, spinal stenosis, which may be something that's attributed towards the causes of spina bifida. How would you know these children? Well, they come in, and one of the main features is the facial abnormalities. They have vision defects. They are often dyslexic and dyspraxic with delayed speech, and they have delayed motor development. They may come to you with developmental coordination disorder. Unfortunately, one of the main problems, and this is why I originally started this talk, was that 26% of those children have heart defects. This is, unfortunately, can be fatal, and it can be sudden. And so it's extremely important to bear this in mind. What are the problems that you could spot? Well, they have very distinct dysmorphic features. They're more obvious in infancy, so the older they get, the less dysmorphic they become. So the younger child, you will often see quite notably, they'll have a prominent ridge, a thin arched eyebrow, infraorbital grooves, a very broad nasal bridge, a short anteverted nose, a thin upper lip, and a smaller than average mouth compared to their head size. And you can see with this picture, especially the one that I think stands out is the very small upper lip, and the nasal bridge is very large, leading to the eyes being quite wide apart. As you can see, in a smaller child, it tends to be a little more apparent, that large nasal bridge, the orbital groove, and the upper lip is almost unnoticeable in this young child, who's really cute, by the way. Some of the more notable but rarer conditions, which would be picked up by consultants, etc., at birth or post-birth, are the split hand syndrome, the colloblastoma of the iris, and repaired neurological spinal issues, which would be relating to the stenosis and to the spina bifida. As far as podiatry implications are concerned, you're going to get some global developmental delay with attributed poor muscle tone and coordination. So you'd be seeing this child probably for tripping, falling, low self-esteem, not coordinating into sports, and generally not keeping up with their peers. Bicycling might be delayed, etc., etc. Poor difficulty keeping up with their families on walks. They're often described as having delayed toilet training due to neurological control, and they're often described as clumsy. Some may be 10 plus before they achieve the normal milestones. This is a condition they will grow out of, although some intervention is sometimes needed if the orthopedic concerns are great. But it is really important to recognise the possibility of sodium valproate, because it needs referral, it needs care, and it needs a follow-on. If a referral needed to the GP, if possible, the most concerning feature of this is the heart. They would need an MRA facial and skull for deformities and possible orthopedic monitoring. But one of the main concerns and one of the main referrals that you would need to is for an echocardiogram. These children need to have the heart checked. They have, 26% of heart defects, and a percentage of those will just drop dead due to heart defects. So if we can do anything for these children, it would be to refer them so that they can reduce the possibility of that happening. I hope you've enjoyed it. If you have any questions, then obviously please don't hesitate to contact me. You have my email. I have got the references if you want those as well. I'm not going to put them here for you to write them all down, but I can send you them if you want to have those and go to sleep. If you're not asleep yet, then well done. I think you've done very well. Now you can go and get yourself a quick drink before the next talk. If you want to ask me any questions, then obviously you can do it on the chat now, or you can send them to me by email or by chat on YouTube. Thank you very much for joining me, and goodbye.
So, I'm Rebecca Rootnerine. Lockdown measures due to COVID-19 has led to reduced outdoor activity and sunlight exposure. So I thought it would be relevant to have a refresher on the role of vitamin D in children. A little bit about myself. I'm currently working as musculoskeletal lead podiatrist at Guy's and St Thomas's with a special interest in children's podiatry. I'm also studying at Staffordshire University, working towards my master's with Nina Davies and Matthew Hill as my tutors. So wanted to acknowledge them both for passing on their wisdom. Today I'm going to cover the role of vitamin D, its sources, and how the body synthesizes and uses this. The role it has in growth and development, risk factors for deficiency, briefly look at rickets, and finally what a podiatrist's role may look like in all of this. Vitamin D helps regulate the levels of calcium and phosphate in the body through a negative feedback mechanism controlled by the parathyroid, stimulating absorption of these from the small intestine. It is important for bone, muscle, and nerve health, so key for the musculoskeletal system. Most vitamin D comes from sunlight exposure in the UK during the months of March to September. Vitamin D is also found in a few food sources, fatty and oily fish such as salmon, liver, mushroom, egg yolks, and fortified foods like breakfast cereals. Breast milk contains vitamin D and it's added to formula milk. Dietary sources alone are unlikely to prevent the risk of vitamin D deficiency. Over the winter months here in the UK, October to March, as days get shorter and there is less sunlight, the body relies on its tissue storages, food sources and supplements. During the COVID-19 lockdown, Public Health England has recommended those staying indoors to take vitamin D supplements. Let's have a brief look into the science behind vitamin D synthesis. UVB sunlight acts on cholesterol molecules found in the skin and converts this into an inactive form of vitamin D, cholecalciferol. The liver converts this further into another inactive form, calcidiol, and finally the kidney converts this into its active form, calcitriol. This final stage is regulated by the parathyroid via a negative feedback mechanism, as you can see on the slide. Calcitriol stimulates the small intestine to absorb calcium and phosphate. Calcium is needed for nerve conduction, muscle contraction, bone formation, and glycogen metabolism. So where does this fit in for children? Bones are made from collagen fibres, which form the cartilage component, and then bone salts, including calcium and phosphate. Young children have higher ratios of cartilage to bone when compared to adults, making them more plastic and flexible. At birth, some bones have begun to ossify, and as children undergo further ossification and grow, the constitution of their bones changes to a higher proportion of bone than cartilage, increasing their rigidity and stability. Some bones, like the navicular and cuneiforms, don't actually start to ossify until after birth. Here is a neonate X-ray where we can see the medial midfoot bones are missing. Physical activity is also important in stimulating bone growth, as it's directly correlated to the amount of growth hormone produced by the pituitary glands. Of course, there are many other intrinsic and extrinsic factors to consider for growth and development, which we don't have time to cover today. Measuring growth is important when working with children, as this is directly correlated with health and well-being. Checking height and weight at your first intervention provides a baseline measure. Getting into the habit of measuring and monitoring growth can help you keep your radar tuned in for syndromes that may affect growth, such as Marfan's. Monitoring BMI could also indicate when onward referral for weight management may be necessary. It is important as health professionals we consider the child's overall health and needs and promote public health issues such as obesity. Here on the right-hand side, is a link for the World Health Organization UK growth charts for girls and boys aged 2 to 18. So what are considered acceptable levels of vitamin D? Blood tests measure levels of calcidiol in the blood, as this is considered to be the most reliable. Levels under 25 nanomoles are considered deficient. Blood testing can be inaccurate as it measures a metabolically inactive version of vitamin D and can be higher than the amount available for synthesis. There is currently no consensus on optimal levels and thus what qualifies as insufficiency. Some studies suggest over 50 nanomoles is sufficient and between 70 to 80 is optimal. NICE guidelines recommend if levels are between 25 and 50, look to treat to prevent vitamin D deficiency. If over 50, reassure and educate. Recommendations and treatments vary between countries. Both the USA and India have far more aggressive treatment protocols. The Department of Health guidelines are for children between 1 to 4 years of age to take between 8.5 to 10 micrograms of vitamin D a day. Sunlight exposure is the most efficient way to get vitamin D. When produced by the skin, it's tightly regulated and does not increase with UVB exposure. Studies have found that vitamin D levels plateau at around 70 to 80 nanomils, regardless of sun exposure. Sun cream does not provide complete protection to UVB and is unlikely to contribute to vitamin D deficiency. There is also great variation on how sun cream is applied. Making recommendations on how much sunlight exposure is required is difficult as there are multiple intrinsic and extrinsic factors to consider. Casual sun exposure seems to be adequate. Research has consistently shown skin is able to create sufficient vitamin D before reddening or burning. Considering all these factors, it's unclear whether the UK needs different guidelines for different ethnicities and skin types. Inadequate sunlight exposure can lead to deficiency, so it's important we understand the child's environment. Do they have access to outdoor areas like parks? What do they enjoy doing? What is their living situation? For example, do they live in a flat with no easy access to the outdoors? They may not be getting enough vitamin D from their food, so ask what is their typical dinner. Children under 5 are more susceptible to deficiency as they're undergoing rapid growth and their cartilage framework is susceptible to remodeling. In cultural practices where skin is kept covered for religious reasons, this will limit sunlight exposure. Darker skin tones are a risk factor as higher levels of melanin in the skin compete for UVB. Therefore, higher UVB exposure is required to produce the same amount of vitamin D as those with lighter skin tones. Obesity can limit the level of vitamin D available for conversion as subcutaneous fat binds to synthesize vitamin D. Certain medical conditions such as Crohn's, livers, or kidney disease can reduce the body's ability to synthesize vitamin D. Some medication can interrupt synthesis as they use the same metabolic system and compete for this pathway, for example valproic acid in children with epilepsy. Pollution also limits the amount of UVB light available to reach the Earth's surface as it scatters and absorbs these rays. As you can see, there are many factors to be considered. People in a higher risk category are advised to take supplements all year round. So how might a child present in clinic? We may get referrals for children who've become reluctant to walk and getting tired easily. They may have a waddling gait. Perhaps they're shorter than their peers and failing to thrive. Thickened ankles or bowing of legs may be of a concern. Widespread pain, aches and heaviness. Regression of motor milestones like trouble climbing stairs. where this was not an issue before. We do have to be cautious when we see these complaints, as they are non-specific and we cannot jump straight to a vitamin D deficiency concern. So it is important to complete a thorough assessment and history. I'm sure you're all familiar with the condition rickets. This is considered a Victorian disease, but incidence has increased in recent years within the UK and in fact globally. It's still relatively rare, however studies have shown a significant number of people do have low vitamin D. It's more commonly seen in children with darker skin, born prematurely or taking medication which interferes with vitamin D synthesis. So low vitamin D levels will result in reduced calcium absorption, defective bone mineralization, and reduced bone density. Bones then become soft and weak, and in extreme cases, we see the classic extreme Geniverum, as seen on the slide. Pain and weakness may be the chief concern, which affects their function, limiting their activity and ability to participate in play with their friends. Low bone density also increases the risk of fracture. When combined with low calcium levels, symptoms worsen to muscle cramps, twitching, even tingling in hands and feet. Important features to look out for are swelling of the ankles, increased Geniverum or valgum, and we may also see wrist cupping as seen in this photo. Geniverum and genivalgum are normal variants we see within typical development, so understanding how to measure these is important. Geniverum is considered a typical variation in infants up to 2 years of age. When measuring intercondylar distance, the medial malleoli should be together and the distance between the medial femoral condyles measured. Around 5 centimeters is normal for children under 5. Intermalleolar distance is the opposite, so knees together and measure the distance between the medial malleoli. 9 centimeters is approximately the normal value for children of 3 years of age. These assessments allow us to quantify the Geniverum and valgum we see. You should also check for asymmetry, extreme angles, low muscle strength and tone, spasticity, pain, limping and swelling. When assessing children, it's important to follow a systematic approach to rule out red flags and differential diagnosis. Following a validated assessment tool such as Gallup or PGAL's screening tool can help structure your assessment and aid clinical reasoning. If following history taking and assessment vitamin D deficiency is suspected, you should refer on to their GP or paediatrician with a clear summary of your findings prompting your concern for further investigation. Remember, this condition is rare. Deficiency is typically diagnosed with blood tests and successfully treated with calcium and vitamin D supplements. If children have problems with absorption, they may require yearly injections. It's easily prevented through diet and sunlight exposure, and podiatrists can help with educating around this. When taking supplements, this should be following the NICE guidelines, as taking too much can cause hypercalcemia. We can educate and signpost to good sources of information, empowering children and their families to make informed decisions about their healthcare. With vitamin D, we can educate on prevention and encourage outdoor activity. Knowing when to refer on to other specialists is a key skill. Getting to know your local referral pathways or being involved in developing these can help build on your multidisciplinary team working. Podiatrists are in a great position to work as part of this MDT, embracing a holistic approach, learning from other professionals and developing pathways to improve patient care and experience. Having a coaching approach to care can help you understand and appreciate the child and the family situation. Work to identify the impairment or cause for concern and how it is affecting that child. What is it they would like to be doing? How does it make them feel? What are their goals and expectations? Look to encourage an open dialogue so you can work together to build a treatment plan for that individual. Children need opportunities to build muscle strength, tone, balance and coordination to attain their motor milestones. Their perception of self and the environment is shaped with experience and learning, highlighting the importance of the environment in their development, and keeping things fun is fundamental. Get families and kids to come up with outdoor activities that they enjoy doing, such as cycling, family walks, playing in the park. Tap into what they already do and start from here. By encouraging outdoor play and activity, we can promote public health initiatives and start important conversations to work towards foundations of a healthy future. I find these infographics produced by the Department of Health are a super useful tool in discussing physical activity and opening dialogue on what children and families enjoy doing. The take-home message is that any exercise and rehab program has to be fun. So you can download these from the links provided. I also often use Hep2Go to create exercise and play programs for children. It's a free resource which is easy to use, and you can check it out at the link provided. So to conclude, we've covered a basic understanding of vitamin D synthesis and its role in children's health, highlighted when to keep your radar on for those who may be in the higher risk category. I hope I can encourage you to see the child as a whole. Vitamin D is only a small factor of the whole picture. Thorough assessment and history taking is important, but so is meaningful goal setting and communication. Make sure you're working as part of the team, with the family and the child, and making use of the multidisciplinary team expertise by strengthening relationships and communication. So here are some references and links you may find useful. So thank you for watching and listening.
Hiya, welcome back. Well, I hope you enjoyed your morning's conference and all the talks, whether you've looked at them today or if you looked at them in the future, whether you've looked at them all together or whether you've done them bit by bit. I hope it's given you food for thought and something you can use in the coming days to come. We're not aiming to change the world or to solve every problem, but hopefully we'll just give you a bit to think about and a little bit of information that can use in that clinic on a day-to-day basis and improve your pediatric podiatry treatment planning. If you have any questions at all, or you're concerned, or you just wish to contact us, please don't hesitate. My email is simonjpod@gmail.com. And if there's any questions for any of the speakers, I can direct them to them and get them to contact you directly. Obviously, we're looking forward to our full conference in March, which will be an absolute image of the one we were going to sit today. And I can absolutely ensure it is going to be top-notch, exciting in a new venue, which we hopefully will be able to access in March. And so we will look forward to welcoming you all on that day. Take care, look after yourselves, and thank you for joining us. Bye.